Good morning, all. So thank you, Kavita Madam and Venkatesh sir, for letting me part of this elaborately planned out scientific session today. So I'll be talking about glaucoma post-vitreoretinal surgeries. So talking in the same lines that Venkatesh sir was discussing today morning. So vitreoretinal surgeries are fast becoming so common in our institutes that is currently the third most common intraocular surgery performed worldwide. And glaucoma is the second most common late complication. The incidence of secondary glaucoma reported in literature varies widely. It goes from around 11% to 60 to 80% in some publications, depending upon how secondary glaucoma is defined, what type of surgery was done, what tamponating agents were used, in what concentration, etc. The challenge in most of these cases is the poor response to medical management, the very aggressive nature of the disease, limited glaucoma surgical options due to extensive conjunctival scarring, poor visual outcomes, and very often quite symptomatic and acute presentations in the OPD, where you have very less time to handle these patients. On the upside, there has been a drastic evolution in vitreoretinal surgeries in the past few decades. The number of scleral buccal surgeries that they are doing have drastically come down. A lot of surgeries now are narrow gauge vitrectomy, which is associated with a less often IOP spike. They use gas tamponates in non-expansile concentrations more often now, and also the use of high molecular weight SO has a lesser incidence of glaucoma. As far as we are concerned too, we have many more surgical options available now. We have easy access to tubes. We have options like conjunctiva sparing techniques like GAT, KDB glide goniotomy, selective laser trabeculoplasty, micropulse laser, etc. Defining glaucoma in these patients, going by literature, secondary glaucoma in these patients is defined as a postoperative IOP of more than 21 millimeters of mercury, or the need for anti-glaucoma medications at or after postoperative day 42. That is defined as glaucoma, and anything before that, an IOP rise or the need for anti-glaucoma medications before day 42 is considered a transient IOP rise, not necessarily glaucoma. So the cause and mechanism of glaucoma has to be carefully looked for in these patients. History of previous surgeries, extent of conjunctival scarring, the exact location of a buccal or a sponge, the IOL type, whether has been a PC breach, the axial length, all these things have to be considered before considering the management in these patients. IOP measurement by Goldman applanation tonometry is of course a gold standard, but very often may not be possible. Eye care and tonopen may also work well in these patients. Non-contact tonometry and Chiards are to be avoided since IOP can be underestimated or overestimated by these techniques. And sometimes in very symptomatic presentations, you may have to just go by manual measurement by digital palpation. It is mandatory to do gonioscopy whenever possible, since angle closure can very often be subtle. And as you can see in this image, very often it is restricted to only the peripheral anterior chamber and hence very easily missed in a routine slit lamp evaluation. Only if you carefully scan the anterior chamber depth to the extreme periphery, you will be able to pick up this very peripheral iris bombe, which can happen in these patients. Hence, gonioscopy is mandatory and to be done whenever possible. Of course, it is to be avoided when there is intense inflammation, hyphema, or a corneal pathology. When required, other investigations like anterior segment OCT, UBM, etc. can be considered. Now, going to the different types of surgeries that we come across often, scleral buccal essentially causes a change in shape of the globe and usually causes a secondary open angle glaucoma. It can also cause angle closure glaucoma by vertex vein compression, choroidal congestion, and anterior rotation of the ciliary body with peripheral choroidal detachment. And these patients respond, in spite of angle closure, they respond very well to cycloplegics and topical steroids. So if UBM shows a peripheral choroidal detachment and an anterior rotation of the ciliary body, it is good to put these patients on cycloplegics and topical steroids, which will pull the iris lens diaphragm backward and relieve the angle closure. Pars plana vitrectomy alone causes secondary glaucoma mostly by inflammation, and it is less common in phakic eyes since there is a barrier to inflammation in these patients. But glaucoma is much more common when there is a tamponade use, either silicone oil or gas. So silicone oil is very commonly used, and glaucoma is the second most common complication following silicone oil use. The incidence is around 11% to 48% reported in literature, and it can cause secondary glaucoma due to multiple mechanisms. In this image, as you can see, this is an overfill of the anterior chamber with silicone oil, where silicone oil completely fills the anterior chamber. And this is easily detected by seeing a golden sheen over the iris. You can see the silicone oil sheen over the iris, and also the absence of aqueous currents, which you usually see a few pigments or cells floating around in the aqueous. That will be absent in silicone oil overfill, completely filling the anterior chamber. Silicone oil can also cause pupillary block. The micro droplets in the trabecular meshwork can cause secondary glaucoma. Emulsification as such can cause secondary glaucoma, and also inflammation can be a cause. After intravitreal gas injection, the incidence of IOP elevation is slightly higher, especially with SF6. It is reported to be as high as 65%, but currently what is commonly used is a non-expansile concentrations of the gas, which is 20% SF6 and 12% for C3F8. And IOP elevations are less common with the non-expansile concentrations. It can again cause secondary open-angle glaucoma, secondary angle closure glaucoma by forward pushing of the iris lens diaphragm. So after gas injection, it is important to instruct patients to avoid mountain climbing and air travel, since gas expansion on ascent can happen as the atmospheric pressure decreases. Again, GA with nitrous oxide, supine posturing, and scuba diving has to be avoided in these patients in the immediate postoperative period. Many of these patients respond very well to anti-glaucoma medications. Topical steroids and cycloplegics also offer comfort. Miotics are to be avoided. And the role of intravenous mannitol in vitrectomized eyes was controversial, but now we have enough evidence to say that mannitol works as well in vitrectomized eyes as it does in non-vitrectomized eyes. And the IOP lowering effect is both due to the osmotic mechanism as well as a central mechanism via the receptors in the hypothalamus. It is important to look for central retinal artery pulsations in these patients. As we know, spontaneous venous pulsations are physiological, but if a central retinal artery pulsation is seen, it's an indication for an immediate paracentesis or a partial silicone oil removal as early as possible. Management by laser may be required when there is secondary angle closure with pupillary block, or when the silicone oil fills the anterior chamber and there is no patent peripheral iridectomy. So Ando first proposed an inferior iridectomy at around 6 o'clock position in SO-filled eyes who were aphakic at that time, and this was in 1985. And the rationale is that when there's an inferior PI and there is prone positioning of the patient, the silicone oil moves to the posterior chamber and saline or aqueous remains in the anterior chamber. But currently with PCIOLs and no capsular breach, PI is not routinely done in all our patients. Whenever there is a capsular breach in aphakic eyes, when anterior chamber IOLs are used, it may be mandatory to do a peripheral iridectomy. So this is the data in about 6,000 plus patients by the authors sitting here. So in this, they found that with this protocol, the incidence of angle closure is quite less, that is about 0.8%. And so it may not be mandatory to insist for a peripheral iridectomy in all our patients. So selective laser trabeculoplasty may be an option in some open angle glaucomas. Diode cyclophotocoagulation may be an option, not just in eyes with poor visual prognosis, but also in eyes with some visual prognosis in SO-filled globes where an invasive surgery may not be possible at that time. As a temporizing procedure, a limited control diode CPC, either by the slow protocol or by a POP titrated protocol, may be an option. Endocyclophotocoagulation, if available, may again be a good option. Trabeculectomy may work in a few eyes with intact superior conjunctiva, depends entirely on how much of the superior conjunctiva has been dissected in the prior surgery. But there are a lot of challenges, including conjunctival scarring, the difficulty in using the full dose of mitomycin in high myopes, deranged anterior segments in these patients, etc. Literature says about 50 to 60% of these patients do well. Excuse me. So in silicone oil induced glaucomas, there are a lot of surgical options which may need to be considered depending upon the scenario. Silicone oil removal as such may work if the risk of redetachment is low and the retina colleague is willing to go for an SOR, and if the oil has emulsified recently or it is non-emulsified. Glaucoma surgery alone can be considered in eyes which are post-SOR, but doing a trabeculectomy or a tube in SO-filled eye may be a challenge because the silicone oil itself can block the ostium or the tube. A limited or a controlled diode laser photocoagulation may be an option in these patients. Another option would be to do a silicone oil removal with the glaucoma surgery or do a phase surgery, silicone oil removal followed by a glaucoma surgery, which most studies say is probably a better option since there is a very high incidence of hypotony reported when a glaucoma surgery is combined with silicone oil removal. Glaucoma drainage devices are often the ideal option, and one quadrant at least has to be intact to consider a glaucoma drainage device. And it is important to look for the location of a sponge or a buckle. It is possible to place a glaucoma drainage device over a buckle, but very often over a sponge is difficult. You may have to remove the sponge and place it over the buckle. An inferior quadrant can be considered in silicone oil filled eyes, and pars plana tubes also may be a good option. Excuse me. Sidoti et al. Proposed the implantation of a silicone oil tube alone without the episcleral plate, which connects to the episcleral plate, which is used for the scleral buckle, and reported good success rates. Another option would be trimming the wings of the Barwell device or the RD, or using the FP8 model of AGV implant, and the smaller 250 millimeters square RD also may be a good option when the conjunctival dissection is difficult. The role of MIGS is still controversial. There are very few small series where GAT has been done in silicone oil-induced glaucomas, and they have reported considerably good qualified success, but long-term outcomes are still unknown. This is a small audit that we did in our department of about 576 eyes, and we found the incidence of secondary glaucoma to be 25.1%. But most of the glaucomas, 98% of them were very well controlled on 1 or 2 anti-glaucoma medications, with only 1% requiring a surgical intervention and 1.3% requiring a YAG laser iridotomy. And the highest incidence of glaucoma was post-retinal detachment surgeries, especially when they were combined with the scleral buckle. To conclude, there is a very high incidence of transient IOP rise and secondary glaucoma post-Vitreo-Retinal surgery. Narrow gauge vitrectomy and non-expansile concentration of gas reduces the risk. Risk is higher with the use of scleral buckle and silicone oil. Identifying the mechanism and ruling out subtle angle closure is critical, and the treatment will need to be tailored for the patient. Thank you.